Thank you, and welcome to the joint CERS-KRS Retiree Health Committee for October the 23rd. At this time, I'd like to call the meeting to order. And Mr. Board, could you read our opening statement for us?
Yes, sir. For the record, I want to note this is a regular meeting of the Joint County Employees Retirement System and Kentucky Retirement Systems Retiree Health Plan Committee. This meeting is being broadcast via video teleconference pursuant to Kentucky Revised Statute Section 61.826 and may be viewed by the public at the Kentucky Public Pensions Authority offices located at 1260 Louisville Road in Frankfort, Kentucky. It is also being broadcast to the public via Facebook. I ask if you are speaking and are not appearing by video, please identify yourself before talking. In the event the video or audio broadcast is interrupted, we will attempt to reestablish a connection. If a connection cannot be reestablished within 30 minutes, the meeting will be adjourned and rescheduled to another date. Thank you.
Thank you, sir. Ms. Rankin, a roll call, please.
Yes, sir. Mr. Powell?
Here.
Mr. Fulkerson?
Here.
Dr. Miller? Mr. Piercy?
Here.
Thank you.
All right, thank you. Quorum is present. And so we'll continue with our business. Public comments, please, Ms. Rankin.
Yes, sir. We have two. The first is from a Robin Mulligan, and she writes, I am for enhancing our retiree health plan. The second one that we received was from a Twyla Coleman, and she writes, I am very concerned with the fact that all the insurance that is offered to retirees with Medicare is a Medicare Advantage plan. All that I hear from any person in health care say is do not enroll in one of these plans. I live in Western Kentucky, and the major hospitals and many doctors in this area are not going to be accepting Humana anymore. I was planning on retiring soon, but will not be able to if this is all the insurance that I am offered. I truly hope that you all reconsider this matter and offer a Medicare supplement instead. My spouse has a supplement that pays everything after meeting his deductible for Medicare, and it is cheaper than what the pension website says Humana cost. Good retirement and insurance has always been a good perk for jobs without great pay, and now you all have taken that away. Thank you.
All right, thank you. Next on the agenda is the approval of the committee amendments for 5th of September, the 12th of September. Any deletions, additions, modifications for these minutes?
Nope.
Hearing
Motion
none. Have a motion and then a second.
Second.
All right, thank you. Any other discussion? All in favor, say aye.
Aye.
Aye. Opposed? Motion carried. Okay. The next will be the Humana presentation with Mr. Lowe and Ms. Lovell. You're on deck.
Okay, thanks, Mr. Powell. Good morning, everyone. If you want to go to the next slide, Sherry, we've got some updates for you regarding primarily regarding pharmacy related topics. So Carrie's going to handle those first three items. I have a few updates, brief updates at the end. So I'll turn it over to Carrie for her to discuss pharmacy.
Good morning, everyone. It's nice to see everyone this morning. Today, we're going to talk through our 2024 annual drug list changes. We do this every year. At the end of the pharmacy section of the presentation, you will find a glossary of terms, just in case there are any terms that some of you may not be familiar with. So we'll go ahead and get started first with our annual drug list changes. From there, we'll move into a brief discussion on pharmacogenomics and then talk a little bit about our medication therapeutic management program. So every year, Humana does make changes to our formulary or our drug list. That only happens one time a year, and those changes take effect in January. There are a number of reasons that we do make the changes every year. One is because new products come to market. So something may be available for the very first time. It needs to be added to the formulary. There may be new generics available on the market. Some of the brand names you may know well have lost their patent, and now there's a generic available. So we may need to move that brand name up in tier, for example, and add the generic. Clinical updates, things change regarding dosing guidelines, the correct dosing. We also have emerging off-label uses sometimes for medications, and that's another reason that we need to refresh our formulary annually. And then finally, price changes. You will note manufacturer price changes or changes in the marketplace that create a need to adjust formulary as well. On the next slide, you're going to see a summary of what the impact will look like this year for the KPPA members. So here we're showing you a 4-month slice of data. This is May through August. We like to use a 4-month window so that we capture most current utilization. We don't go way back in the year because then we might capture things that people just aren't taking anymore. So we do have a 4-month slice of data here to show you what the impact will look like. We base the percentages on 60,476 total members. You will see that we have 4 categories of change that we evaluate: the not covered, prior authorization, step therapy, and tier change. And we're going to go into detail about what's driving the changes that you see here. We also have a number of positive changes that take place. So positive changes are things like coverage is added for a drug that may not have been covered before. A drug may be moved to a lower tier on the formulary. We may have removed step therapy or removed prior auth. So those are examples of some of the positive changes that you see. I will point out, I had a little typo. The total column says 3.1% member impact, and it should say 4.0. I actually punched in the 1.0 for prior authorization as 0.1. So I apologize for that. So that should say 4% for your total impact. And like I said, we'll talk through the changes. And just for comparison, as we went into 2023 last year, there was 5.85% impact, and then 4.2% positive. So less negative impact this year, a little less positive as well, but overall less change. As you go on to the next slide, we'll get into what's causing the changes. You did see some coverage change, and I don't want that to alarm you at all. We have 885 members that will be impacted by coverage change, but the majority of that is due to a new diabetic supply strategy that we are implementing for 2024. So we will have BD products and HTL products preferred, and that is going to be new. In the past, we had not had preferred diabetic supplies. But so in 2024, all insulin syringes, pen needles, those types of things, BD and HTL will be preferred. The good news is 71% of all of our Medicare membership already uses these 2 brands. Any brand other than these will be considered non-formulary or not covered. But the way that healthcare providers typically write the prescription, they write it so the pharmacy can just fill for whatever they happen to stock. So the providers don't really have a preference as to what brand members are using. They just write it so that the pharmacy can supply the member with, whichever brand they happen to stock. And switching brands doesn't require a new prescription for this at all. So that is the majority of the coverage change that you see here. Yes.
What does BD stand for in HTL?
Those are just brand names.
So
it's just BD. Yeah. And I don't know, I don't know what it stands for. I just know that there are BD syringes and BD pens.
That's fine. Thank you.
I can look that up for you, Connie.
I actually knew that one because my dog uses the BD.
Okay.
Yeah, it just says BD, but we'll look it up and I'll let you know if there is something available that those stand for. We'll be sure to let you know. The other two things are kind of interesting. Something that we don't see that often, but Flovent Discus inhaler and Onglyza, a diabetes medication, are both being removed from the market by the manufacturer. And it's not for safety reasons or anything else. They just decided to stop making those products. So this is not really a Humana change in coverage. It's just a market change in coverage. Not related to safety or anything else. They just decided for whatever reason that they weren't going to make these two products anymore. The next category that we have is prior authorization, and you're going to see 577 KPPA members that may be impacted by a new prior auth requirement on the medication that they're taking. The largest one in this category is Levemir, and it's just because we are moving it to non-preferred, but it is a long-acting insulin, and we have 3 other preferred long-acting insulins on our formulary. So we've got Lantus, Toujeo, and Tresiba. Those are all going to be preferred products. There are minimal clinical differences in the long-acting insulins when we think about their ability to lower blood glucose. So we will have 3 preferred products. This one will just move up to tier 3 in the non-preferred position. But if you remember, last year we talked about a new insulin copay cap. So even though the Levemir is moving up to tier 3, it will be capped at $35 because that's the insulin copay cap. Then the other new medication the other medication requiring prior authorization is going to be buprenorphine. It's a narcotic analgesic, 38 members impacted by that one. And then Daliresp, a COPD medication, and 18 members are impacted by that one. And the Daliresp does have a new generic available to market. So those 18 people can just switch to the generic. And that's what the prior auth will require. If they cannot take the generic for some reason, then they'll need to get that PA. The next category is step therapy. We have a projected impact here of 152 members. Advair Discus is the first one that you're going to see. And again, that's because there's a brand new generic equivalent available on the market. So people will just be asked to try and fail the generic for Advair first before moving on to the brand name. And then the next one is difluprednate. That is an ophthalmic steroid. It's a very high cost generic, and there are lower cost generic options available. So that's the reason for the new step therapy on that one, just because it is so high cost. And then finally, we'll just talk a little bit about tier change. Projected member impact there is 779 members. We've already talked about Levemir. That one is changing just because it's moving to that non-preferred position. Lagevrio is an anti-infective for COVID, and that one is also changing tiers. And then finally, the Advair Discus that we just talked about, it's changing tiers as well because of that new generic equivalent that's available. So that's really just kind of the summary of the changes that you'll be seeing in 2024.
Before we move off the page here, I'm concerned about the diabetic supply with the brand names, because I know, like I said, my dog's been a diabetic for a while now, and depending on where you go, it's a different brands. Will the members be notified of these changes? And what if the pharmacy doesn't carry one of these twos? Are they going to get assistance to find a supplier for those?
Yes. So those are great questions. They will be notified of their changes in their annual drug list change notifications. And we'll talk about that as we get a little deeper into the slide deck here. But yes, they will be notified that that's changing. Most pharmacies do stock one of these 2 branded products. In the event that someone does not stock either of them, they would just need to apply for a formulary exception.
Okay, because I know because of the prices, there's a place I go to that the guy that started, his name was Sam, and they use Relion as their syringes. And that's the only one I've ever received from them. So that's why I was asking about that.
Yeah. Yeah, they would either need to, ask if the pharmacy would be willing to order the brand that they need, or they could apply for a formulary exception, one of the two.
Okay. Thank you very much.
All right, and we'll talk a little bit more about that
Tanya?
communication.
Just to interject real fast, Carrie, BD stands for Becton Dickinson is the name of that manufacturer. The other one must be a conglomerate or something. It's called HTL Strepa is the name of that company. So as Carrie said, it's just the name of the manufacturer.
Yeah, thank you, Larry. All right, we'll move on to the next slide. There is another change coming for 2024 that's not exactly a formulary change, but I wanted to share it with you all. It's just a little bit of a change in how coverage will occur for certain situations. And we are doing this to align with CMS guidance. So in 2023, payment for provider administered medications, if they're dispensed from a pharmacy, depends on whether the pharmacy ships the medication directly to the provider's office for administration to the member. We call that white bagging. And in that situation where the pharmacy ships it to the office for administration, that's today covered under Part B, as in boy. The other situation that can occur with provider administered meds is the member picks the medication up at a pharmacy and transports it themselves to the provider's office for administration. That's called brown bagging, and that's covered under Part D, as in dog. So today we have two different scenarios. The white bagging is covered under B as in boy. The brown bagging is covered under D as in dog. That's what happens in 2023. In 2024, beginning January 1st, any provider administered medication dispensed from a pharmacy, we will be billed under Part D as in dog, regardless of whether the member picks it up at the pharmacy or continues to ship to the provider's office from the pharmacy. So both the white bagging and the brown bagging scenario will be billed under D as in dog in 2024. Now, what this could mean for your KPPA members, they may see a change in cost for the medication. If their Part D benefit is a little bit different from their Part B benefit. Some of the medications may require a prior auth to pay under Part D, as in dog. And then impacted members, anybody who's impacted by this is going to receive a letter in November just about this topic to let them know that this change is going to be coming and to let them know if their medication will require a prior auth. These meds will be eligible for a transition fill. And we've talked about transition fills before. That allows the member to get up to a 30-day supply in the first 90 days of the new plan year, so that if they do need a prior auth and need some time to work through that with their provider, they'll be able to get their medication as usual in a transition fill until they can work through that. And when we looked at the preliminary numbers for KPPA impact, it looked like about 117 members. Now, that number could go up or down a little bit between now and when we do the final data pull for the letters in November. So people could stop using those meds, or a few new people could start using a med in that situation. But when we get a little closer to the November mailing, I'll be able to give you a more exact or current count, but that's just a projection based on what we saw in early data.
And Carrie, you said that this change is driven by CMS rules. We really were allowing the either or approach in prior years, but technically that doesn't meet CMS guidelines, and so that's why this change is being made for 24.
Right.
Do you think, Carrie, that they're going, well, I guess it would depend on if they have to have the medication for a long period or short period, but I was looking at the members' out-of-pocket costs should be cheaper with a copayment at the Part D form benefit versus Part B, which is a $500 deductible, then 4% of the cost. So
yes,
it's possible, but if they're on long-term, then it might, you know, because after the $500 deductible and the $1,200 out of pocket, you're going to max out. But still, I would think the copayment might be a little bit more affordable for them as well. Would that be why Medicare did that? Maybe, I don't know. Just wondering.
I'm not sure what drove the decision, but there will be instances where it could be advantageous to some members
Yeah.
from a cost
Okay.
perspective.
Thank you.
You know, maybe not all the time, but there will be some. And the majority of claims that we saw for all of our Medicare members in this category, it was Prolia and Botox. So Prolia is an osteoporosis med that members only fill once every 6 months. And then the other one was Botox for approved uses, not Botox like you're thinking of, but Botox for approved uses like migraines and eye spasms and things like that. So those were the two main drugs that we saw when we looked at the data.
Thanks.
So we'll move on to the next slide. And we have talked a little bit earlier this year already about the GLP-1s. Those are a type of diabetic medication used to treat type 2 diabetes. You know, you've seen and heard a lot in the news about the potential for these being used off-label for weight loss. So starting on 1/1/24, all members who are using one of these will need a valid diagnosis of type 2 diabetes. The pharmacy dispensing system has been built so that we're going to have an automated look back for other types of diabetic medication, diabetic supplies, and we're also going to have a crosswalk to our medical claims. If the system detects any of the presence of any of those things, it will just go ahead and pay the claim. There won't be any disruption to the member at all. And even if the system doesn't detect those things, the pharmacist at the pharmacy counter is going to have the ability to enter a diagnosis code at point of sale if the pharmacist knows that the member is diabetic. So I don't really expect much noise or disruption at all here. Members who do have a medication that will be impacted by this new update will get messaging in their smart summary the month that they process a claim. So from now through the end of the year, they're going to get messaging in their smart summaries that they do have to have a diagnosis of type 2 diabetes. And I have a list here for you of the medications that will be impacted that will require that diabetic diagnosis because that's what they're FDA approved for. All right, moving on to the next slide. Just a couple new vaccines that we wanted to mention. You may have heard in the news that there is a new RSV vaccine. There were actually two. One of them is applicable in the Medicare population because it's for individuals 60 years of age and older. The other one is really not applicable, but I just wanted to mention it as well while we were talking about the RSV vaccines. The new RSV vaccine is covered on Part D, as in dog. It's always confusing how these vaccines are covered. So I just wanted to go ahead and share this with you all in case anybody asks. RSV, Abrexvi is on D as in dog. And then the COVID vaccines, of course, are covered under B as in boy. And both are zero cost share to the members. All right, moving on. So as we prepare for these upcoming changes, just wanted to share with you a little bit about the communication that members will be receiving. As always, they're going to receive their messaging in their smart summary in October, November, and December about those upcoming drug list changes. And then member letters, they're also going to be this year getting individual personalized letters sometime in mid to late November regarding the changes for 2024. And then the transition fills do apply. Again, that 30-day transition supply will be available to them in the first 90 days of the new plan year. If they are impacted by any of the 2024 changes, that way they can still get a 30-day supply of medicine while they work with their healthcare provider on, making an adjustment if needed. And then, as I mentioned before, members will be receiving messaging in their smart summary about the diabetic meds requiring diagnosis, and then they will be receiving an individual letter about the white bagging situation where that will be moving to all Part D. So lots of good communication going out to the members to keep them informed. Next slide. All right. Now we're going to talk a little bit about pharmacogenomics. And I know that this has been a topic of interest for you guys. We talked about it a little bit last year, and I just wanted to kind of revisit where we are with it, talk a little bit about what CMS does and what Humana is doing. Just as a refresher, pharmacogenomics is a word that gets us all tongue-tied when we try to say it, but it is really just the study of how genes influence a patient's response to the medications that they may be taking. And this can vary from person to person. You may have a drug in person A where a normal dose works just fine. That same drug in person B may only need about a half dose just because of the way that medication works for them and in their body. And then patient C, the drug might not work at all. So this is just a very dynamic area of medicine that changes frequently. We do have an integrated health solutions team and a patient safety clinical programs team on the pharmacy side that are constantly monitoring pharmacogenomics and what's going on in this area of science. We'll move on to the next slide. So we'll talk a little bit about Medicare coverage. Today in 2023, CMS does not cover pharmacogenomic tests for predictive purposes or broad panel testing. Predictive testing is the type of screening where a member really doesn't have any signs or symptoms of a particular disease. Broad panels just look for any type of gene variation that could, affect a wide list of medications. Single gene tests, however, are a much more focused and precise way to look for gene-drug interactions. So CMS does cover the single drug gene testing for some medications that they have deemed it medically necessary to cover it for. So just to kind of review, CMS is not covering those broad sweeping tests for kind of, everything but the kitchen sink. However, CMS does cover really targeted testing for particular situations where they think it's clinically important to get this testing done. I think we've talked through, an example before that, FDA labeling for certain seizure medications, Tegretol, Dilantin. They do recommend that genetic testing be done for patients with Asian ancestry, just because patients with this ancestry are at a much higher risk for life-threatening skin conditions due to certain genetic composition. So the covered testing must be ordered by a physician or a qualified healthcare provider. And the member-initiated tests that are advertised online and on TV, those are not covered by Medicare. Right now, we're not aware of any changes that will be occurring with regard to the way Medicare covers these in 2024, but we have provided a link here to all of the information from cms.gov around how they approach genetic testing. If we move on to the next slide. Last year, we shared with you that Humana was doing a pharmacogenomics pilot. And when we think about a pilot, it's really like a scientific study where there's an intervention group and a control group and lots of metrics and measurements taken. So we are currently conducting a pilot of MAPD individual Medicare members. And the pilot was being conducted to evaluate the value of genetic testing in guiding therapeutic decisions and to really look at the impact on long-term outcomes, things like medication adherence, hospital admissions, readmissions, and cost of care. And to do that, to really get strong results around that, we needed, 6 or more months of medical claims data to be able to evaluate that. And then we also wanted to determine if this was a process that should be expanded on a larger scale and applied to other markets or other populations. The results are being evaluated in Q4 of 2023. And what they're working to determine is whether outcomes demonstrate a return on investment that would support a larger rollout. So today, Humana doesn't offer a pharmacogenetics program or benefit, but we are doing a very thorough scientific type study of whether or not we should roll out a pharmacogenomics benefit.
Carrie, let me ask you a question. Can you share how you identified the people in the study? I mean, are you using the broad approach that you mentioned before, or is it specific diagnosis you're looking at?
Well, I'm not able to release just yet.
That's right.
Once they have the results, I think there is a plan to release those, and I will be able to share at that time.
Thank you.
And we'll be happy to share at that time. I know this is a very hot topic for you, something that you have a lot of interest in, and I have let the team that is actually working on the study as our patient safety team. And I have let them know that KPPA has a very genuine interest in this topic and would be very interested in learning more and being the first to learn more about it as soon as those results are available, and should we ever decide to roll it out in larger form.
Yeah, great. Thank you. Great.
All right. And then I wanted to talk today a little bit about medication therapy management. I think we mention this sometimes when we do our Plan Compass review. We may have mentioned it briefly in the past, but I wanted to take some time today to go a little bit more into detail, just so you're aware of the benefits that members who qualify for this program receive. Medication therapy management is a federally mandated CMS mandated program, and our program is really set up to optimize medication therapy. We want to promote safety, we want to promote efficacy, and we want to help the members save money so that they can achieve their best health. So the goals of the MTM program are to optimize the therapeutic outcome or the effect that the drug has, improve the way that members are using their medication, so improving adherence, improving compliance, making sure that side effects are minimized, that we don't have drug interactions, and making sure that we can find any way to identify and intervene to improve care of the member. And we definitely strive to achieve improved health benefits and cost effectiveness. If you move to the next slide, I wanted to share with you the criteria that members must meet to qualify for this program. So this is not something that every KPPA member would qualify for, but some of your most complex members, some of the sickest members, would definitely qualify for this based on these criteria. They have to have 3 of 5 chronic conditions, and for 2024, those conditions will be osteoarthritis, CHF, COPD, diabetes, and depression. That is different from 2023. In 2023, the target conditions were schizophrenia, hypertension, CHF, osteoarthritis, and asthma. So every year I think there are about 9 different disease states that CMS allows us to choose from. And so we choose different target conditions each year so that we can expand the reach of the program. Rather than reaching out to the same people over and over, we want to try to reach as many members as we can. And so each year we do make some adjustments to the target disease states that are part of the criteria. The second piece of criteria that the member must meet is they must be likely to incur the annual Part D medication cost of $5,330 for 2024. This is a threshold that is set by CMS, and every year it gets adjusted kind of with inflation and as things change. But in 2024, the criteria will be $5,330 of annual medication cost. And then they must be taking a minimum of 8 or more chronic maintenance medications that are Part D drugs. So members meeting all of these criteria qualify for the medication therapy management program. We'll move on to the next slide. So the way this works is the members who qualify receive a letter, and throughout the year, we are constantly scanning the data to identify the folks that qualify. We send them a letter and invite them to participate with the program. This letter offers them either a face-to-face consultation with their pharmacist or a telephonic consultation with the pharmacist. And the pharmacist really does a thorough medication assessment. We call it a comprehensive medication review. They go through every prescription medication and not even OTCs or herbal supplements that members may be taking, just to look for any medication-related problem, whether it's a drug-drug interaction, a drug-disease interaction, whether they may be taking medications they no longer need, whether the dose is too high or possibly too low. It could be subtherapeutic and not working for them. So the pharmacist that does this one-on-one consultation really looks at everything related to the drug therapy. And it results in the creation of an individualized summary in a standard CMS format for the patient to have to take with him or her to their next provider visit. So they get a medication action plan and a personalized medication list after they complete their consult. So it's really important for members to complete the consult. And I just wanted to show you, how many members you've had eligible, how many have completed their CMR, their comprehensive medication review, and what that completion rate looks like. In 2023 through August 21st, you had 3,324 members complete their CMR of the 4,894 eligible. So you had a CMR completion rate of 67.9%. Below that, you're going to see the KPPA data for 2022. For the entire year of 2022, you had a 77.2% completion rate. And then I did show you just a couple of peer groups, other large state health plan retiree groups that are very similar, both in size and geographic location to the KPPA members, just so you can kind of see what their completion rates look like in comparison. This program offers a lot of the features that you may be hearing about, from others, because they're getting that one-on-one interaction with a pharmacist, whether it's that they're a retail pharmacy contracts to provide MTM services, or whether they receive the telephonic service from Humana or Humana contracted pharmacists. So it's a great service and a great program. And, please encourage the members, if they are eligible for it or receive communication about it, we definitely want them to set up their consultation and participate. On the next slide, just a few things to show you some advantages of participation in the program. We have studies that have shown that the members that participate in MTM have fewer inpatient hospital admissions. They have better clinical markers and better medication adherence. So definitely some advantages when members participate and receive this medication review. And that really concludes the pharmacy portion of the presentation today. I know it was a lot. We covered a lot. So thank you so much for your time.
Thank you.
Okay. think we've just got a couple more updates. If you could go to the next slide, Sherry. Did want to update you all. We have been out in the community with your members this past, over the past month or so. Humana hosted meetings around the state. You can see the locations listed there. Had good attendance at those. We'll report out on that once they're all complete. We also hosted a virtual meeting for your membership. We've also been attending, and these are actually, you know, not even a current count. We've had a couple that have popped up just in the last couple of days with the KPR chapters around the state. So always happy to attend those meetings. Those are, we love to attend those. They're, you know, well attended also. And so I think there's two more that are not even shown here. So always happy to attend those. It's a built-in audience, so we're happy to get part of the agenda for those. We use those meetings to talk about, certainly this time of year, you know, any, you know, sort of 2024 planning, answer member questions about really whatever it is that's on their mind. And these actually occur with the KPR version throughout the year also. So not just this time of year, but we attend these meetings on occasion, you know, throughout the year. So always happy to do that. Going to go to the next slide. I did want to provide a quick update on the Baptist Health Medical Group contract situation. Really no material update. We remain in active negotiations with Baptist. So they continue to be out of network for Humana. The good news for your membership is that they are seeing our group Medicare members on an out of network basis, which for your population means really no change in the members out of pocket costs, because that benefit is the same in and out of network. We have seen some instances where the messaging to the member has been a little confusing, members getting turned away or feel like they're getting turned away. So we've intervened on those. If you have those issues come up, please route those through Connie and get them to our team, and we will make outreach to the member and to that provider to ensure that there's no care disrupted. In the meetings that I talked about that are occurring, Tracy and our other staff, there's a what we call a member to provider flyer. So there's something tangible that your membership can walk away with that they can take to their doctor that explains how the out of network benefit works, so that your membership isn't disrupted. So that's a topic of conversation in those meetings. Yes, ma'am.
I wanted to ask, I wanted to enter here. We've got a copy of that PDF on our open enrollment page for Medicare, which starts today, by the way, open enrollment for Medicare. And so they can print that and take it with them. And you all are also giving them out during the meeting. I know you're in Louisville today, but in the meetings. So I think
yes,
that's going to help as well.
Yeah, there's an electronic copy available on the KPPA website that we maintain, as well as the physical copies, like Connie said, that are available in these meetings. So again,
Ms. Pettyjohn,
we're in active. Yeah.
Yes.
Could you email a copy of that to Mr. Totten so he could put
Larry
it on
Totten. Yes,
so he can put it on
okay.
KPR's site,
will
so the members can
absolutely
have
do that.
access to that easier.
Yes, sir. That's a good idea.
Okay, that's all I want. Thank you.
Yeah, we know that they are seeing our members, but there have been some situations where, you know, front desk person might not be aware, or there's just a confusing message potentially. So we're always happy to intervene on those.
And I wanted to add, if I can, right here, because we've been out, myself, I've met Tracy at some of the meetings. Brian Tolles has been out in Lexington. I went to Frankfurt, Louisville. 80 retirees at one, 45 at another, and none of them reported any access to care issues. They took my name and number if they had any reported, like somebody else, family, friends, whatever, but they've not had any of these issues. And they know to call us. So, and I just wanted to share that with you all.
Yeah, we're doing everything we can to get them contracted back into our network. So we will keep you all updated as soon as there is any change to that status. Should that occur, you all will be first to know. So optimistic that will get resolved in the near future. You want to keep going, Sherry? Just one quick update, on the Go 365 program, which is our sort of wellness and rewards program. So your membership, for those of you who aren't aware, Go 365 rewards your members for engaging in healthy activities, either in the form of preventive services or things like exercise and fitness and other even social and health education activities. So the program has evolved over time. And the way we think about this program has increasingly been around the star rating program from CMS. So we want to encourage those activities that align with the categories within the CMS star rating program that ultimately lead to better star ratings and better outcomes for your membership. So you'll see on the screen there for preventive screenings, members can be rewarded in the form of gift cards for completing various kinds of preventive services. So things like their annual wellness visit, getting a mammogram, getting a colorectal screening. For 2024, for diabetic screenings, there will be a requirement that to get the $50 reward, they have to complete all 4 tests. So the diabetic eye exam, a hemoglobin A1C, their diabetic kidney function tests. So there's a 4 test requirement in order to get that specific reward. There are others, as I said, for the annual wellness visit, mammograms, and other screenings that are still available sort of on a standalone basis. Under exercise and fitness, that is a $5 per month to a maximum of $60 per year for, going to your Silver Sneakers gym and things like that. And then under social and health education, again, that's less sort of tied to star ratings and those sorts of activities. So we added the ability to get rewarded for those social and health education activities a few years ago. It's the maximum dollar amount that's rewardable for 2024 is coming down. I believe it was $40 this year. It will be $20 next year. So it's sort of the incentive dollars are sort of being geared more towards those actual preventive screenings and the fitness and activity items there. So it's a program that we're sort of always looking at to figure out where are those incentive dollars sort of best spent. Any questions about any of that? Okay. That's really the end of our presentation. Welcome any questions that you all may have.
Thank you, Mr. Lowe. And Ms. Lovell, we appreciate your all's input and guidance here.
Thanks
Mr.
for having
Patty
us.
John, I believe you're up next.
First, I want to share what those retirees in those KPR meetings said to bring back to you, the board. A big thank you for the premium reduction for their contribution plan and the essential plan on MA plans. So they said to let you know they appreciate that. feel like you're, working with them. And I had no negative comments about Baptist or any access to care issues. And they're using, of course, we've told them to contact us. I've given them my phone number, my contact information, and I've had very few that needed it. So I feel like they're receiving the benefits that they expected, and there's no disruption majorly. I may have had one or two, but I think Humana helped us with outreach and had talked to the provider about how to bill, and that easily resolved the issue. So I wanted to pass those things on to you. And then Abby Sutherland, she's the Assistant Director for Retiree Healthcare, is going to give you a brief snapshot of open enrollment till now. We still have the Kentucky Employees Health Plan non-Medicare eligible open for open enrollment through Halloween, the 31st. And then today is when Medicare eligible open enrollment starts and runs through November the 30th. And so she's going to give you a snapshot here of kind of what we've been seeing so far. Thank you, Abby.
These are the statistics for October 1st through October 15th, and this is just related to the KEHP non-Medicare enrollment. And we're doing a comparison between 2023 and 2024. On the first graph there, you can see that our online enrollments are down a little bit for the first part. And then we have a slight increase in what has been processed by our staff here at KPPBA. The next one is for the Form 6256. That is our form that hazardous duty retirees are required to complete annually in order to receive contributions for their health insurance dependents. We're about the same for the online completion of the form as we were last year, but our staff has been able to start processing the paper forms that we had received so far this year. If you'll go down. We do a lot of different communication efforts with our retirees. The most common is phone calls, which for the first part of the month were down quite a bit. For that point last year, I will tell you there was an uptick in calls last week. Our emails are down a little bit from last year, but our virtual visits and in-person visits are about the same as we had last year. We did send out our annual open enrollment email notification. About the same amount were delivered to retirees. We had more that viewed it this year, and we had more that utilized the links that were attached in the email this year. For additional outreach, we did webinars for the KHP plan. Once those webinars were completed, we put a recorded version of it on the website, and we've had 240 views of the recorded webinar. We also attended the KHP benefit fairs that Department of Employee Insurance did. The majority of attendance was Frankfurt, which is typically our largest attended one. And that's all the statistics we have now. We'll give you a complete snapshot in February. Do you have any questions?
What, unless I misread that, what do we attribute the massive increase in the paper 6256 to?
Well, we normally receive those every year. We do have members that don't complete it online. They send in the paper. It's just this year our staff has been able to start processing them earlier.
Okay.
Yeah, there were less phone calls, and we've been able to do a little bit more processing this year. So we're just a little bit ahead of the game than we normally are.
Okay, I got you.
Being ahead of the game is good.
Yes, very good.
Anybody else have any questions for Connie or Abby? Ladies, thank you very much for your presentation today. Very informative as usual. Does anybody have anything else they wish to share with us today, or questions regarding our healthcare plans? Hearing none, that concludes our agenda. And then that being the case, we will adjourn the October 23rd meeting for the joint CERS-KRS Healthcare Committee. Thank you all for being here.
Thanks. Bye.
Thanks.